We're going to go ahead and move on with the next session, our Health Disparities panel, addressing health disparities in Missouri. You know, it's really tremendous for us to be able to have the good fortune of national speakers at our conference, and we still have two more today. But in many ways, the real power of this Health Policy Summit comes from the networking of all of you. And so, again, we like to make sure to invite you to our networking reception at the end of the day. But it also comes from having state leaders talk to us about what we're doing in the state and what we need to do and what we're learning and where we're going and how we need to grow in the future in these important and critical areas of health and health care. So we're going to start this morning's panel and talk about health disparities. I have just a couple of introductory slides, and then I'll introduce the panel. We're not alone, of course, in this. Missouri Foundation for Health has started a tremendous initiative addressing health disparities in Missouri, and this is their first report, Minority Health Disparities in Missouri, focusing on African Americans. This is it's a little bit old, a slide of the percent of African American population in this state, and we can see there are some concentrations around the state which present us with interesting challenges and maybe some barriers, but also some tremendous opportunities. They've continued their work for their second data book, Minority Health Disparities in Missouri, focusing this time on Hispanics. This is a slide with a Hispanic population in Missouri, a little more diffusely populated throughout the state. And interesting enough, if you look from 2000 to 2003, we have tremendous growth in the state of our Hispanic Latina population, and an area that we will have to continue to focus on in the future. As we talk about health disparities, we can talk about both health care disparities, about what we do with people when they hit our doorstep in the healthcare system, and how we treat them, and whether that treatment is equal and equitable and culturally competent. But we also can deal with health disparities in the broader sense of what are the conditions that lead to differences in outcomes. And you can see here that we have the percent of Missouri population below poverty in 2002. You can see the emphasis area, especially in the southeast and some in the north as well. We have a large percentage of our disparities come from lack of insurance. In Missouri, we don't do too badly in terms of health insurance coverage, but there's always room for more growth in that area. I want to talk just very briefly about what we're doing. This is our summit, and so I guess we get to toot our own horn a little bit. We're currently partnered with the Health Policy Center at Washington University. Dr. William Peck and Debbie Chase are partners there, along with Tim McBride from St. Louis University, to examine health disparities in rural and urban Missouri. And we're going to be focusing, MU that is, on the Boot Heel, and Washington University is focusing on the St. Louis region. And again, this is sponsored through contract with the Missouri Foundation for Health, and we're just so thankful for their focus on this area and for their support. Now, we have a lecture series that everyone is invited to at the University of Missouri. It's a lunchtime lecture series, and I can get you more information about that if you'd like. There's also another lecture series that Washington University is putting on. We've completed our task force. It's a 3-campus task force from the University of Missouri system, included UMKC and UMSL and the University of Missouri. We recommended 31 changes for the University of Missouri system to address health disparities and health care disparities, and we're starting to implement those changes right now. We have a number of other collaboratives, including telehealth interpretation services that are still just growing. Now, the only thing that I'd like to say at this point is we have this tremendous panel here, but there are other people in the state that are working in this area, and we're hoping in the future to bring you all together for a conference sometime in the spring to continue this kind of collaboration. Edna Chavez is in the audience, and she's been working in this area. Tim McBride, Arif Ahmed and his colleagues at University of Missouri, Kansas City, working on health systems research. Loretta Prater, who's a dean down in Southeast Missouri University, who has recently started with a mobile van to reach out to underserved communities. So I'd just like to make sure that everyone is aware that we have a lot of attention to this issue in Missouri, and we'll be focusing on it as we move along. So today, I think we're going to use a slightly different order. I'm a bit embarrassed because I don't have the time to introduce our panel to the extent that they deserve to be introduced. These are tremendous people who've done some amazing work in the state, and so I'm just going to take 2 minutes and introduce all of them, and then and this is the order in which they'll be speaking. So first we'll have Eduardo Crespi. Mr. Crespi is the founder and director of the Centro Latino de Salud, a community nonprofit organization based in Columbia, Missouri. Then Dr. Cynthia Frisbee, who's an associate professor of advertising at the University of Missouri School of Journalism. Ms. Leslie Reed, who's the vice president of health policy from Missouri Foundation for Health and one of our key partners. Ms. Joy Williams, the division chief, Office of Minority Health and Division of Health and Senior Services. Dr. Will Ross, an associate dean and director of the Office of Diversity at Washington University School of Medicine in St. Louis. Dr. Janetta Craig, who's the chief medical officer for the Family Care Health Center in St. Louis, Missouri. And I think that does it. I think I got everyone there. Yes, very good. Mr. Crespi, you're first, and we'll hopefully have just a few minutes for questions when we're completed.
Hello, good morning. First of all, I wanted to say thank you to Chris for inviting me to participate in this conference. I think it's very, very important for him to invite a Latino immigrant that somehow is making it in this environment, and yes, and one day decided to just open a non-for-profit organization and do good to people, you know. And sometimes people say, well, how do you do that? And I didn't have the answer really, but then one day I said, oh, I got the Spirit, or the Spirit got me, one or the other. But I want to tell you that the Centro Latino became a reality as just it was a school project, all right? I was a nursing student, and I had to do something. So then I became an intern with the Office of Minority Health when Benjamin Germany was the chief and Joy Williams was the other chief, all right? And all of a sudden Centro Latino became a reality because don't tell me, show me. You know, this is the state, the show me state. So, you know, I said, oh, show me state, that's what I have to do, don't tell me, show me. So Centro Latino was created, was opened in the year 2000, April 1st, April Fool's Day, all right, yeah. But anyway, since I received the invitation via email, I've been thinking about what am I going to tell these people about health policy. All right, and I thought, well, I had to do a PowerPoint presentation, and I started it, you know, and it was a very nice little sign coming like this with the clouds in the back, and it said, relax, and then the other one will come in and say, I will not preach to the choir, and I will not, because you all know statistics, numbers. What am I going to show you? A map where the Latinos are? No, you want the juicy stuff. Yeah. And the juicy stuff comes from here. So, you know, I have a few notes here. But in the way of getting to understand the kind of population that we serve, I want to tell you that we serve the low-income, underserved, uninsured, non-properly documented Latino population. That, curiously enough, is the larger amount of people. So we serve the mass. We serve the thousands of people that are out there that are not covered by anything. And one of the problems that I was going to say is that the lack of policy. That's what we have. We have lack of policy. There are no policies for our Latino people, the working class that we serve, all right? But anyway, the health policy that might affect our Latino people goes together with the immigration policy. Because one of the biggest problems that we have is our immigratory status. So until the immigration policies don't change, we cannot do much about our health policies in terms of our Latino population working class. Definitely, we all know that one of the barriers for access to health, language, definitely, and the immigratory status, one of the most important, I believe, besides language, because we can always find an interpreter, or we can find a 5-year-old kid that speaks a little bit of English, and we can tell him, oh, you know what, your mom has cancer. Things like that. That happens, you know. But the problem is that even if a Latino person speaks the language, how to navigate the system, it takes a long time. Even people that were born in the United States, maybe in the border area, it's not easy to navigate the system. Tell me how many professionals are here that are struggling to get paid by Medicare, the Medicare system or the Medicaid system, or even from insurance companies. You have piles and piles of bills to send to these people, and then they send them back, and you spend hours and hours on the phone trying to get paid because you saw a patient. So that's what I'm talking about. It's something that navigating the system is very difficult. Anyway, I have a little story. I was driving this way, and I started imagining, you know, this man waking up in the morning to go to the second job. He takes a look at he lives in a trailer. He looks at his bedroom. There is his pregnant wife, and a little 3-year-old started to, you know, to awaken, so he tries to leave. Drinks the leftover milk that was left there last night for his 3-year-old kid, and maybe a piece of something, bread or something on the table. That's true. And they go out, and then there is a car. A little prayer, that person still has some hope and faith. So a little prayer that he will not get stopped because he doesn't have a driver's license to go to the second job. And he continues thinking, how am I going to afford my wife's pregnancy? Of course, she's going to weak, you know, and we get a little bit of help there. And then the 3-year-old, daycare, how do I do that? How much do I make? And this and that. Now, imagine that person a white man, all right, for a second. Now, imagine that person a black man. And now imagine that person a Latino, okay? These problems are beyond ethnicity and race. This problem is a problem of humanity. Humanity in the hands of our representatives that can change the policy in the future. Now, the Latino has another problem besides being poor, besides having a pregnant wife, besides having no money, 2 jobs, no driver's license. His immigratory status. That person might not be properly documented, because if that person is properly documented, he might have a better chance, he might be living in a house, he might have a driver's license, so no worries about it. Now, definitely that brings a lot of mental health problems, issues, depression, and waiting for Friday to buy the 6-pack. So everything adds up to our family. Now, the idea of the case scenario here is real, it happens every morning, is that brings us to another part of our health policy. The pregnant woman that is resting, she's going to wake up sometime, and she might have the need to go somewhere to shop, buy bread and milk, whatever they had to shop with, the money that they had to shop with. Now, while that woman is in the United States, that fetus that she is carrying is a U.S. citizen. That's why we have to take care of that U.S. citizen, potential U.S. citizen, that we have to take care through WIC, for instance. We give them good nutrition, good prenatal care, and everything. Let's say that that pregnancy comes to 8 months. You know, she's almost ready to have that baby. That baby is a U.S. citizen. It's a U.S. citizen. But all of a sudden something happened, okay? And she gets caught by the Immigration and Naturalization Service. And that person is deported, okay? That fetus that was a U.S. citizen until that day, that day becomes an illegal alien. So are there any rights on that particular human being that is going to be born? There was a little mistake, something happened, the taillight of the car was bad, and she was stopped, and all of a sudden she didn't say the right words, she's gone. Now, listen to this. It's okay, she goes back to Mexico, she has the baby in Mexico, that baby is born in Mexico, is a Mexican citizen, a legal alien for us. What happened is that the whole family is in the United States. So that woman gets the baby and said, we are going back home, because home is in Columbia, Missouri, where grandma lives, where grandpa lives, where all the sisters and brothers and everybody lives here. So this is home. She crosses the desert 3-4 days, enduring. They come back to Colombia. Now, what do we have? We have an illegal alien that we have to take care of. It doesn't qualify for anything at all. No benefits, nothing. So think about that example. What do we do with that? I mean, is there a solution for that? Who do we talk to? I mean, there are laws now that I bring that subject because it's so controversial. Abortion, non-abortion, choice, no choice. There was a murderer that killed his wife that was pregnant, so he has 2 convictions because he kills 2 individuals. But when it comes to a little Latino kid inside of the mom's wounds, then we forget about all that? Okay, well, I don't. So I have 2 minutes. Okay, so now that I brought you the kind of ideas that you can have to mature that this is a bigger problem than what you would think, I want to say that the Missouri Foundation for Health and your office, Chris, are doing a good job in terms of trying to fix these problems. And a few years ago, I saw the beginning of this telehealth network, and I saw it in Kennett, Missouri, in a little community place, I don't remember the name of the place. I went there to do some work with the WIC program. And there it was. And I looked at the power button, and it was brand new. So that means that it wasn't used. That was 2 or 3 years ago. I hope that now that system is being used because it's a good system. Now, I will say this. I've been a nurse in different hospitals for a few years, and I never heard of telehealth. We never used it in a hospital. As a nurse, I never seen it. As a nurse, I never heard any other nurses saying, oh, you know what, we have this system in the hospital that works so great. We could do this, and that. I never heard of it. But I browsed the website of the office, the agency, and it says that it's being placed in different strategic areas in the state of Missouri, and I think that that's a good start, and I hope that it will be used. All right? We could certainly benefit. Steve Hall is there from the Boone County Health Department. He's doing a great job with social services for our Latino people, and certainly we could use a little bit of telehealth networking. When clients come to our Centro Latino and they have to go to the health department or the family health center, the phones don't work that well, but maybe we can press a button and say, hello, here I am, Mr. Rico, please talk to Steve Hollis and see what happens. And anyway, one more thing, I know, but this is important. I check on since this is a policy, I check on some of the bills that are being introduced, and there were 57 bills introduced. This is in the website here. And only one that was voted do pass, thank God, sponsored by Timothy Green, a Democrat, young politician, long career, and Catholic. It says, creates a tax deduction for small businesses and farmers that provide health insurance for employees. Small businesses, the deduction will be equal to 100% of expenses related to providing employees with health insurance. Good, because we have Latino people coming to the United States with working visas to work in agricultural kind of work. Agriculture, also cutting the grass, that is considered agriculture. So we have lots of landscaping companies employing Latinos that come with working visas. Now, this is a pretty beautiful bill, and 1 out of 57, that's good for me, it makes my day. And yes, I hope it will be implemented. But the change in policy for the immigration in order to help our Latinos for the health is that they should open the horizon of working visas for other professions. We have people working in construction. Construction is very dangerous. People get hurt every day. So why not to open working visas for other professions? So saying that, I wait for your questions later on, and thank you very much for listening, and I hope you got kind of an idea of the kind of world that we are dealing with every day. Thank you very much.
All right, next we have Dr. Cynthia Frisbee.
Wow, I have to tell you, I am very honored to be among you this morning, because as I looked through the registration list, it's doctors and health policy people, and here I am, an advertising professor. So thank you for your time and attention as I share some of my research. I am very interested in looking at, well, I started out with breast cancer in African American women, and how I stumbled on this area of research was simply because I was in the race for the cure for a friend of mine who I watched her go through chemotherapy and all those things that you have to do as a breast cancer survivor. And as I was at this race for the cure, I was looking around and thinking, why aren't there other women who look like me? Well, gosh, I didn't even think about me being a woman that needed to think about breast cancer, because remember, I was doing this for my friend Helen. I was a woman in my 40s at the time and not even thinking that breast cancer was something that I should even be worried about. So I started from there. I went to look at, well, what was going on? So what I found out was very startling. At the time, this was in the late 90s, I saw that the mortality rate for African American women was 3% higher of that of Caucasian women. And reasons for that were even mind-blowing as I kept digging into that. Some of my friends said, well, you don't really need to do that research because it's certainly socioeconomic status. And I started thinking, well, no, that wouldn't explain it, because I am middle class. I was educated, and still am educated. I didn't lose that, I don't think. But here I was at this race, and I'm thinking, I didn't think about it for me, so that explanation doesn't work for me. What might I find? And what I've listed here were some reasons that the research kind of revealed for reasons that African American women or blacks in general not only avoid detection but going to the doctor. Spirituality, and I'll go through these real quickly because I do have 8 minutes, maybe 9 max, but spirituality, that's an interesting variable and one in which I'm tweaking with right now in some research. We know from looking back at slavery times, spirituality and religiosity is crucial at helping us through some tough times. That is one of the key variables that helped us to get through slavery and some of those really tough times. And I see it in my family where you say, how are you doing, Grandma? And just pray for me. I got a little problem with my blood, but just pray for me. Did you go to the doctor, Grandma? No, just pray for me. And they don't really oftentimes share what's going on. So spirituality is a major variable. How do you address that when we're talking to this community? And I'll talk about that in a few minutes. Socioeconomic factors, again, that's a no-brainer there. Going through just attitudes regarding screening. One of my studies, and we'll talk about that, found that, again, there were some attitudes or some misperceptions about the disease and lack of knowledge. Again, lack of advertising, and I'll talk about that. Just general anxiety about breast cancer was another thing that research revealed. The interesting thing, and being the advertising professional that I am, I did realize that, well, gosh, maybe the reason that I and some of my other fellow women in my culture don't think about breast cancer is because how many ads do I see that have women who look like me that say, you can survive breast cancer, or get yourself checked? How many ads do we see that promote health care issues that have people that look like us? So one of the other things, just to mention, you saw on the slide was cultural beliefs, and that's in your handout. MSNBC did a story, and I don't know if any of you remember that. It was on about 5 or 6 years ago on one of the news channels, and they did this study where they asked African Americans what they believed about health care. And what was really interesting was the fact that spirituality, again, the idea that God gives it to you and he can take it away, and this kind of fatalistic attitude. So that was interesting when it came up under cultural beliefs. And another variable that came up too, and I don't know if it was on there, but distrust of the medical community. And one of the things, and we could talk about that for days, but will we ever get over that syphilis study that happened in the 50s? And what was interesting about that was, in some of the research, I'll talk about that, that came up again with people in that actually weren't even born in the 50s, but they heard about that particular study. So under cultural beliefs, we have that living, well, actually, and it was a very real thing that happened, but tends to kind of stay with us. And so I'll talk about how I address that in my studies as well. I did, my first study after that race was looking at ads and just kind of thinking, remember, I was just, well, maybe I don't see a lot of ads with people like me in them. So I did just a real quick content analysis and looking at the ads that appeared in Ebony and Essence for 10 years. Started out when I think President Clinton, it was, declared October National Breast Cancer Awareness Month, so we went the years before that and then after that to just look and see what kinds of ads are in there that tell us about this disease, or and will we find any that promote information about the disease. What you'll notice is that I found that there were more ads about raising money. So, for example, Avon had a lot of buy this purple pen. You guys probably have seen that little purple pen. I'm not purple, pink, with the, of course, the breast cancer symbol. It was, you'd give money for that. Dark and Lovely had a lot of ads in there where if you buy the relaxer, they'll donate portions of their profits to breast cancer awareness. So that was very interesting. Over the last 10 years, we found very few ads that could actually address or inform our people of what breast cancer is and how the disease is treated. So after we did that, I started a stream of research. The first one was just Messages of Hope, I called it that. I surveyed 92 African American women living in Washington, D.C. of all ages, starting from age 16 all the way up. The oldest person in the study was 92 years old. And what we found in that particular study was very interesting. The women, I think it was less than 1%. It might have been out of the 92, maybe 3 women could correctly identify one of the 6 risk factors associated with breast cancer. That bothered me. I don't know about you, but to know out of 92 women, the probability of how many should be able to correctly identify the risk factors should be a little bit higher than 3. And so that was startling. The other thing that came out of that research, that study, was women expressed an incredible desire for more information. They said, if we could just see some ads that tell us about how we get this disease. When we asked them to list the first 3 things that come to mind when you hear breast cancer, guess what the number 1 thing was? Avon. So they talked about that pen that you could get with Avon. And the second common category that came up was Susan Komen's Race for the Cure. So that was interesting. A Matter of Life and Death, I looked at some emotional strategies, and actually what I wanted to test out was the data that a lot of women said, here's what we need in the earlier study. We want to find out that there are people like us that have had the disease and how they're coping with it. So I tested out some ads. By the color of her skin, I looked at whether or not the endorser had to be black or white, and what the impact was of that. Bridging the Gap, again, I just looked at what are some of the stories or things that we see in magazines, and do those relate to some of the top 10 diseases that are in our community. What I found, basically, again, and I think I don't have much time, but we found in looking at some of the magazine stories that African Americans read or are exposed to, in fact, none of the stories really dealt with some of the broader health issues like diabetes or stroke or high blood pressure. So that's something very interesting for us to consider. This ad we created and tested. Again, remember, one of my passions is to see, do we need to see people like us, and should we have older people, older women that say, here's what I learned. One of the things a lot of the focus groups and studies that I've conducted have shown is that women basically said that they needed to know that there are women like me doing it. That was the one thing. But we also found that in our community, black women are the matriarch and the patriarch. They're the head of the household. So we tested out and to see if we could show black women that are strong and getting through some of the tough times. In this particular one, we also wanted to appeal to what we found in research that women said, well, what if he won't like me, or he won't prefer me, or I won't be attractive? So this one says, the copy we basically wrote said, he wanted me to do it, and he loves me regardless, and he stuck with me. So here's another one we created. I think my students helped me, and they did a great job, because actually these look like real ads. I hope you think they look like really ads. This one is tapping at the matriarch/patriarch, and because he calls me mommy. So we felt like by doing this and showing some of that, who's going to be around if you don't take care of yourself to take care of him? So what impact do these ads have on African American women and getting them more involved? Because he calls me, oh, look at you, I heard you guys up here. Oh, well, that's exactly the impact we wanted with that ad. And just to let you know, we did an experiment, the study that you saw, the emotional strategies. These are some of the ads that we tested, and we did find after exposure to the ads, involvement and concern for breast cancer was really high. I didn't get to follow up with it, but when we asked them their intention to get a mammogram, that was really high after exposure. So we did a pre and post test on their attitudes. So this is just where I'm going to leave you. You have it in my handout, but where I'm going to head, I'm still working on that. I'm working on spirituality and designing an ad that tells, actually relates to that spirituality thing, but how can you compete with God? We're not really going to compete with God and say, you know, there is no God or anything like that, but we're going to say, using biblical scripture, that the body is the temple, and he tells you that. And so in order to take care of your temple, you must take personal responsibility for your health. God wants you to do that, and that's the messages, that's what we're testing out right now. I know that was quick, but hopefully we'll have time at the end for questions. Thank you so much.
Thank you, Cynthia. And now we have Leslie Reed from Missouri Foundation for Health.
Good morning. I have a few more slides than the previous speakers. It's very good to be here. And it sounds like the Foundation's getting known. We've been out there a few years now, but just wanted to remind you, especially based on what it is I want to talk about, that the Foundation focuses on the uninsured, the underinsured, the underserved, and filling gaps in services to these groups. And while we're doing this, we're in the health policy area working to promote positive health system change. And health disparities are a significant issue that we focus on throughout our work. Chris showed you our publications. There are copies outside if you're interested in seeing the data books on Hispanics and Hispanics and African Americans. They're there, and if there aren't enough, please let me know if you'd like a copy. I'm going to give you a little peek inside, because what I want to show you is that inside these books, you see issues where there are disparities by race in our state. This is from the Hispanic Data Book, where we were able to look at death rates among the major racial groups in the state: Hispanics, African Americans, and whites. And here you have infant death rates. You saw these through David Satcher on more of a national level. These are obviously very crushing and inspiring. The books also show you, the African American book especially, where you can see the disparities by place within Missouri. Jackson County has a rate of 5.9 white infant deaths compared to 15.4 for African Americans. But when you jump down to Greene County, you have 6.7 white infants dying compared to 27.2. So there are real disparities across the state, differences in what is occurring. And then here you see the HIV rates are very different among the different races in the state. And this morning, listening to David Satcher, was really reinforcing of what it is that we've been noticing as we go out through the state and have community forums. We are really noticing the disparity of access to health care. And David Satcher talked about those in the context of Healthy People 2010, looking at the top and bottom bars outside of the determinants of health, the policy and interventions, as well as access to quality of care. And that's what I'd really like to speak about. And I'm going to need to jump from national to Missouri in order to create the full picture. In America, we have, in 2004, 46 million uninsured individuals, and this equals the combination of the populations of 24 states. Obviously, these would be states with smaller populations. However, it's an interesting way to think about how many people don't have health insurance. And African Americans and Latinos experience greater increases in these than the rest of the nation. As insurance coverage disappears or becomes less comprehensive, costs paid from individuals' pockets increase. And as you see that the minority populations, health insurance rates are decreasing and also their incomes are decreasing, this creates a problem, a significant problem for us. And here is a chart looking at from 1987, projecting through to 2013, that the insurance rates, the uninsurance rates are projected to continue to increase. And I just want to give you a little piece of context for some of the ways that people talk about levels of income. The federal poverty guidelines are often quoted and we rarely see them. And this is a context for considering income levels. If you look at the family of four level, $19,000 for four people to live on, and then often you hear about 200% of poverty, which would be about $39,000 for four people to live on. And now I've borrowed from the Commonwealth Fund's Need to Transform the U.S. Health System a number of these slides, and you can see that at low income levels, whites, African Americans, and especially Hispanics have high rates of uninsurance. And these low income individuals have access problems and financial stresses. And we've come to determine this as medical debt. When people are choosing not to get care because they don't have enough money, they're not insured, they don't have enough money to pay for the doctor, or perhaps they are underinsured and they don't have enough money for their copayment or their deductible. And there are a lot more of these individuals who are contacted by collection agencies about their medical bills and who choose to change their way of life because they cannot pay for medical bills. Again, you see overall in the U.S., Hispanics, followed by African Americans, have the greatest rates of uninsurance. And then one other point I wanted to make using this, if you look at the top two lines here, those are the two lowest income brackets, and they're experiencing the sharpest uninsurance rates. But if you look at the third line, it also shows a significant incline. That's 60% of the total population of the country facing increasing risks of uninsurance. And this really depicts a developing health trend here in the United States, a disparity relative to uninsurance. What really interests me here in Missouri is what's happening here in this state. Now, when we go out and we meet with people in the community, we often ask, and these are meetings that are touching on uninsured, and we say, how many of you have a family member or a friend, someone in your immediate circle that you know that is uninsured? And we get a lot of hands raised. And I'm wondering in this room of thinkers and providers, how many people know someone who is uninsured that's close to them? I would say that's a third to a half of the room. And does anyone know someone who has just lost their Medicaid coverage or will soon lose Medicaid coverage? It's a really sad picture here. So this is my Cover the Uninsured Week image that I really enjoy. We began our work through the Cover the Uninsured Week. What I want to move on to, if you'll pardon me, is that the reason so many of us know someone who's uninsured is this, that and these are new figures. Last year, some SHADAC figures came out and some CPS figures came out about the uninsured in Missouri, and they were disparate. And so our board asked us if we would please do a study and find out what is a more accurate reading on how many uninsured people there are here in the state of Missouri. So Tim McBride can proudly, he's back in the audience, see his numbers up on the screen. In 2004, we estimate that 10 to 11% of Missourians were uninsured. And in 2005, that estimate rose to 11 to 12.6% of the population. So we're using a confidence interval. I love that term, that we have 550,000 to 620,000 uninsured in Missouri in 2004, and then 635,000 to 707,000 in 2005. So if you think about 10% as the low figure that's here, that's 1 out of every 10 people at the table doesn't have health insurance in the state. When you look at the country, back in 2003, even in 2004, you see Missouri. It's got the striped lines through it. We don't look so bad. We were actually in the top 12 states, for uninsurance. However, last year we did have Medicaid cuts. And so there's a real change going on in Missouri. By July 2006, there's an estimated 90,000 to 104,000 adults who will lose their Medicaid coverage, and an additional 20,000 to 23,000 children who will lose coverage, largely because their parents can't pay for their premiums. And so this will shift Missouri out of that state with the hashed lines, where they're one of the 12 states with the lowest uninsurance rates, to one of the states with the highest rates of uninsurance, one of the 12 states. And by my calculations, Tim might disagree with me, but that will put us in the summer of 2006 with no other changes in the insurance rates in the state at 745,000 to 834,000 uninsured in Missouri. It's a large number. The Commonwealth Fund did a poll with healthcare opinion leaders across the country, asking what it is that they really would like to see as priorities for Congress. And the top issue was to expand coverage to the uninsured. And then just jumping down a couple, you see some that really relate to this particular conference. Addressing racial and ethnic disparities is number 7. Just above that is controlling the rising prescription drug costs. Further, the survey goes on, and here you see what would you like to see as achievable and desirable target goals for policy action in the next 10 years. This is obviously a national level survey. The first 2 lines there look at an interest in reducing the rate of the uninsured, going from 18%, please excuse me, down to 8%. And number 2 is, thank you, Chris. Number 2 is an interest in stabilizing the cost of health care coverage, and that going from 15 to only 16%. As we know, that would be a real shift from the ways that costs are increasing right now. And then number 3 is a reversal in the trend of employer insurance. Right now, there's decreasing employer insurance, and these leaders wanted to see an increase in employer-provided insurance. Now, when we go out to into the public and we meet with people in communities like Ava and Greenfield, we hear these stories. And that was really what I wanted to tell you today, but some of these statistics are so fascinating. Let me just tell you one story about some of the inefficiencies of what's happening right now. There was a gentleman in Dexter, which is down in the Boot Heel, and he was a construction worker, and he was there with his teenage daughter and his wife. His wife had some health problems, and as a construction worker, he was an independent contractor, and he made a good salary. However, because he was an independent contractor, he could not buy group insurance. He had to buy individual insurance, and he couldn't afford it. And his daughter was not covered, his wife was not covered. He looked terribly worried, but he had this look on his face like, it's not me I'm concerned about, it's my family. He was unable to qualify for Medicaid because he makes too much money. So he's in that gap. He's working steadily. We've met people all over the state who are working, who are unable to afford insurance. And some of the interesting situations, there was another one, this gentleman who was on Medicare. His wife How am I doing on time? 2 minutes? Okay. Okay. His wife had her durable medical equipment cut through the Medicaid cuts, and no judgment on the cuts. However, just the inefficiency of the fact that she wasn't going to get her nebulizer provided by Medicaid, and she then was going to have an 80% chance of being in intensive care with pneumonia over the winter. So what's the balance here? That's very difficult for me to reconcile. Now, interesting things. As we went out and talked to Missourians, here's what they're really looking for in the communities we were able to talk to: available, accessible, consistent health care services when needed, affordable prescriptions. We connected so many people to the drug companies' free and low-charge prescription programs. And interestingly to me as well is that the Missourians would like to contribute toward the cost of health care coverage within their means. I just want to remind you of the federal poverty levels. One person we asked, what would you think is a fair amount for you to pay toward your doctor's bills? And that person said, well, it depends how many meals you want me to miss in a month. So as we consider what is affordable for people, we need to consider housing, food, the basic necessities of life that include health care, but what is actually going to keep individuals healthy. I'm trying to figure out what I can wrap up with without okay. So as we address health disparities due to lack of access, it allows us to address some of the underlying factors that are related to race and place, the disparities related to race and place. And creating a system that provides access to affordable, consistent health care provides a basis for dealing with other significant health disparities. As Dr. Satcher said, because more African Americans are on Medicaid in this country, in this state, if we work on our access issues, we will also work on some of the most powerful underlying issues for some of our minority communities. And with the Medicaid Commission working to restructure what's going on with Medicaid, if they were to look more broadly at the state's health system, there is an opportunity for us to create a more equitable system that we're hearing Missourians ask for. Thank you.
I know what my job for next year is going to be, and that's going to be how to learn to work this. Sorry, Stan. Thank you, Stan. Next we have Joey Williams from the Office of Minority Health.
Good morning, everyone. Eduardo and I were sitting here, and we had decided that we were going to have to come up with funds to identify an intern to work PowerPoint for us. Because, you know, and we do very often. Today I did not prepare a PowerPoint presentation simply because I tend to inundate the audience with data without having the opportunity to talk about what's really going on at the community level, as well as having time to get feedback from the audience as to what they see needs to happen or what is currently happening that is working and no one knows about, which very often is the case. Again, I do want to say good morning to you. It is a pleasure to be here. It is wonderful to see so many people that are inspired this morning to work on or work with health disparity areas. Coming from the Office of Minority Health, that has always been our mission. One is to, although not officially, it is the mission of our hearts, is to inform the communities as to what are the issues that you're actually dealing with that you may or may not know about. And two, it is to inspire people to want to attain a better health status. And when we talk about health, we're not just talking about a physical health, but we're talking about mental health as well as other social healths. I wanted to let you all know I've been in the Office of Minority Health for about 5 to 6 years now. And in that time, I feel like I have learned far more than I could probably ever share with you. But one of the things that I have learned is the notion of disparities is not new. It's not new to the minority communities. It's not new to the medical communities. It's just not a new notion to us. We constantly talk about the the Tuskegee Institute, the Tuskegee experiments, and the impact that has made on our community. But in all actuality, sometimes that might be a topic of a discussion, but minority communities have often felt like, irregardless of whether it was that study or not, that we were being treated in a disparate manner. So the concept of disparities is nothing new to us. One of the things I do want to let you know, a few little data points, it's always a responsibility to kind of let you know where we are, is that there are some areas that we are particularly concerned about, not only in the African American community, but in the Hispanic community and in the Asian and Native American communities, that our HIV/AIDS rates in minority communities are astronomical. The African American population in the state of Missouri is about 14%, but we constitute about 50% of all new infections within the state. If that's not enough to scare an audience, I don't know what is. When we start talking about infant mortality data, as Leslie pointed out, our infant mortality rates in the state have been closely monitored over the past, 10, 15 years, and we have made significant progress, although we're not seeing any reduction in the disparity. And as a matter of fact, and looking at our state, we fall probably right in the middle in terms of overall state infant mortality rates. We're right there in the middle of the pack. But if you look at the African American population, Missouri ranks in the top 10 worst states for infant mortality outcomes. I don't know if people understand what that means, what the impact of that really is in terms of health policy, in terms of health resources, and in terms of community engagement around infant mortality. Of course, cardiovascular disease is our number one killer, and minority communities have always been at greater risk of dying from diseases associated with cardiovascular disease. So, these are the kinds of things that we want to always be able to inform community about. And I think right now, one of the things on the top of our list is the issue of obesity. The obesity rate in minority communities right now is such that if it's an indicator of what's to come, then we need to be out recruiting healthcare providers in droves. We need to be creating them from the womb, because our obesity rates right now are such that we're going to be dealing with extremely high numbers of diabetes, extremely high numbers of cardiovascular disease, probably increased rates of cancer, as well as we're going to be looking at an increased rate of infant mortality. We're going to see the little bit of progress that we've been able to make over the past 10 to 12 years begin to decrease because of our because of our obesity factor and our lifestyles that are supporting some of these illnesses. Now, one of the disparities that we know exists but we don't know a lot about in the state of Missouri is the disparity in health care provision. As much education as we would like to provide and as much screening as we would like to provide, if the health care provision is not being provided at a level of parity, then we're still never going to make progress in terms of course, of more mortality rates. There will be no progress, and we are not able to treat everyone in a manner in which our standards of care require. And that's something that I think we are constantly going to have to battle. And from a policy level, we've got to begin to talk to our physicians as well as talk to their clientele as to knowing, being aware of their environment, being aware of their individual cultures, and how we are because I think we all play a part in supporting this disparity, and that we have to begin to take responsibility for assuring that we are all receiving the care that we need. So, learning a little bit more about the healthcare disparity in the state of Missouri, I think, is really going to assist us as policymakers in terms of not necessarily ensuring, but at least assisting in making some changes there. During my tenure, the office has really been focused on community capacity building and advocacy. One of the reasons why we've decided to go that route is we're finding that very often people in the community are not necessarily as receptive to the individuals that are coming to them to help them. And it could be the government we're here to help syndrome, or it could be, a variety of things that allows people or prevents people from being receptive to those providers. So from our perspective, we're like, well, we need to begin to build the capacity of communities to care for themselves. And that does not necessarily always mean a physician or a nurse, but it does really require that there be an elevation of health awareness in communities, and how we do that is through community-based organizations. So we really want to begin to work on building a capacity within the community to address health. And it doesn't necessarily have to come out of a health community-based organization. It could come from a social community-based organization. It could come from any kind of service or entity. We're really wanting to build some capacity there, and advocacy also. Now, in doing the capacity building and the advocacy, our hope is to increase or diversify, it would be a better term. We're hoping to diversify the numbers and the types of individuals that are being leaders in our communities around health issues, as well as providing the health care. I think when you begin to look at Dr. Satcher's continuum of care diagram that he presented, it really did touch upon the diversification of that workforce and being prepared to address the underserved population. And I have 2 minutes, so I'm going to rush. The work of Disparity Reduction Missouri has to be, from my perspective, I always have to say, use that disclaimer. From my perspective, it has to be developmental, that there are places that we have to develop the talent, we have to develop the inspiration, we have to develop the resources to address health disparities. Then it has to be community focused. And when I say community, I don't mean a city. A city is not a community. Communities very often are self-defined areas, and so it really has to be community oriented, community focused, and then family oriented. No man is an island. Nobody is doing this all by themselves, even if they think they are. And so we really got to begin to do more family oriented, holistic perspectives around health to begin to develop real policy statements around and policy work around health disparity reduction. And in doing all of this work, I think one of the things that is a consistent undercurrent is that there's got to be some cultural competency within the systems, and cultural competency at the community level. And with that cultural competency, we are also encouraging individuals to have more of a social competency. And anyone who has talked to me recently, not even recently, probably over a year or so, I've really been pushing an issue of social competency. And I think Hurricane Katrina brought that to a head when we started to look at poverty. Now you're starting to hear discussions around poverty and the state of poverty within our country. But we've got to be a little bit more socially competent, that sometimes race and ethnicity are not the only things that are forcing us to make the decisions that we're making. So that's one of the things that we are really pushing, and that there are different kinds of skills and different levels that we've got to be able to operate, as well as different levels at which we need to be engaging. Because it is not about race or ethnicity. It really is about humanity, because if you're beginning to work on health disparities, you are increasing health access and the quality of care for everyone. And I guess what I should do is kind of close on that and hope that we will have an opportunity to discuss things a little bit further if we have time for a Q&A. Thanks.
Thank you. Now we have Dr. Will Ross, who's from Washington University School of Medicine.
Thank you, Chris. Morning, everybody. We heard this morning about health disparities, and we don't need to go through the data because we know they exist. I think it's important to just skip the slide just quickly. Okay, I skipped a slide. Although they exist, unfortunately, we do have a problem. We have a disconnect between the magnitude of the problem and our perception of the problem. This is an interesting and almost humorous portrayal of our views of health care that was discussed and presented by Robert Blendon from the Harvard School of Public Health in the New England Journal last year, showing that among the top issues that were being considered during the 2004 presidential election, racial disparities ranked number 9 on the list. And in fact, even among African Americans, it ranked number 6 or 7. And so we look at issues of costs and prescription drugs and drug benefits and uninsured and Medicare, and we keep forgetting that all of these issues have elements of racial disparities. And somehow we've relegated to a separate category and something that we can sit in the corner and someone else will study. And as a consequence, we don't have the national focus on racial disparities, despite the fact that we've spent so much money. Winston Churchill said that what is it about us Americans? We're a positive group, right? We will always, in the end, do the right thing. Eventually, we will do the right thing. The problem is that we're going to spend so much money in the process of doing the right thing. You know the data. We spend, end of this year, $1.8 trillion, 14% of our gross domestic product on health care. I like this slide because it really differentiates the health care financing into the 3 major categories: hospital care, physician clinical services, and prescription drugs. We know that number is escalating, and I see no reason that's going to change because our focus hasn't changed. What is even more troubling, however, is the converse: how much we actually spend on public health financing that will actually address the issues of disparities, that will actually address issues of prevention and behavioral modification that will be necessary to reduce overall health disparities. This number has been flat since 1985. We spend 1 to 1.2% of our GDP on public health. Unfortunately, that's a travesty, and I also see no sense of change or urgency regarding this statistic. Now, because we have these incredible expenditures, we expect a great outcome in our health, and we don't get this. This is data I borrowed from Jim Kimmy at the Missouri Foundation for Health. His data is abstracted from here in Jefferson City at our Department of Health and Human Services, showing that as a state, we fare poorly compared to the other 49 states. From a standpoint of a number of clinical parameters, whether it be cancer deaths, obesity rates, smoking rates. The red shows the Missouri, and the I guess the green, and from there it shows the rest of the country. So we're faring worse, despite the fact that we're spending so much money. Embedded in all those statistics, of course, is this issue of racial and ethnic disparities. Some of you were there in New York when Alan Nelson, who was then chair of the Institute of Medicine, presented this at the press club. I was there, and I recall how he pounded on the podium. He said, "Look, we know this exists. I'm tired of talking about this. I'm tired of the data. When are we going to do something?" And it just reminded me of another great philosopher, an American philosopher. His name was Cedric the Entertainer. And Cedric said, "Well, what are you going to do about it?" Well, okay, what are we going to do about it? We know it's there, and so I'm not going to give you the definition of racial and ethnic disparities. Issues that we can't simply allow these things to continue. Now, we've chronicled some of the disparities in St. Louis, and I'm going to talk to you a little bit more about process and policies. What are we going to do about these things? In St. Louis, you can see in this graphic an array of healthcare indicators, disease indicators, from low birth weight to cancer mortalities and overall mortalities. And we're looking at the relative risk of these diseases compared to the white population, with obviously the relative risk one being a higher incidence. And you can see for almost every indicator there's a greater disease burden among African Americans. What we additionally found out, however, was that there is, of course, an element of social determinism, that none of these diseases exist in a vacuum. And this was, of course, highlighted by Dr. Satcher earlier, that when we look at these diseases, we have to interpret them according to the environment. We have to look at the issues of unemployment, female household heads, the lack of high school degrees, average household income, and we can see that these things follow pari passu. They follow in conjunction with the disparities. And until we address these social determinants, then all we're doing is simply talking and talking and talking, and nobody's doing anything. So let's go back and say, how do we address this? And we really have to start looking at the literature, the evidence is out there, which has been fairly pronounced, has been paramount for years, about how to resolve healthcare disparities. And this is abstracted from a great review in the American Journal of Public Health. There are six simple processes. One, we want to make sure that it's universally accessible. We want to make sure it's high quality care, and this is affordable. When we do that, that will address most, but not all, of these healthcare disparities. And I'm going to show you additional information to document that access by itself is necessary but not sufficient to resolve healthcare disparities. We want accountability in this system. We don't know who's in charge. And most importantly, where is our public health infrastructure? I mean, why on earth are we spending 1% of our GDP on public health and then 15% on sick care? Something is wrong. The system, we don't have a system. It should be abolished. It's not functional. I do mean that it really should, we can't tweak this system anymore. It's not working. It's not functional. We need to have a new system. And I'm going to skip this data because that's been covered earlier. You can't review this. You can't see this from the back, and I do apologize. I just put this together. But this goes to my earlier point about the role of health insurance in reducing the disparities. And this is a report published by Blanton and Hoffman at the Kaiser Foundation in Health Affairs earlier this year. It's a great review. Please pick up Health Affairs, the March and April edition this year. And in this review, they actually reviewed a number of studies, 4 studies looking at the contributions of insurance in explaining healthcare disparities in two populations, Hispanics and African Americans. And in one, I will need to use the in one column, you can see that the access gap, for the most part, you'll see that there is a 5 to almost 15% access gap between African Americans, Latinos, and whites. Whites are that's a 15% difference in how in their access to care. How much of that is explained by insurance, and how much of it is explained by income? For the most part, about in this column, you can see that anywhere from 20 to 30% of this gap is explained by insurance, not 80 or 90%. Only 20 to 30% is explained by insurance. Another 14 to 15% is explained by income. But for the most part, when you go back and review this, the percent of the gap unexplained in Latinos, anywhere from 30 to almost 60% of the gap is unexplained by insurance. In African Americans, the numbers are anywhere from 10 to 50%. Unexplained by insurance. And so, as I stated earlier, healthcare insurance is necessary, but it's not sufficient to reduce health disparities. I want healthcare insurance for all. It is one of the seminal goals that were outlined by the American Journal of Public Health article. We should still go and promote that, but it's much more complicated than that. What do we do about this? Again, let's just back off. This is a policy meeting, and I appreciate the fact that this is a policy meeting. What are we going to do about this? How do we promote a sustainable action in order to reduce healthcare disparities? We have to start looking at our own report card. We have to create a report card. We have to look at the benchmarks that are going to be incorporated into that report card. And then we have to make this public. One, we need to have a running total of insurance gaps. What is it year by year? What is the difference? How is it stratified, of course, according to race and ethnicity? We need to comment on workforce diversity, which is also necessary but not sufficient to resolve healthcare disparities. I'll make a quick comment on that. We have an Office of Minority Health, but do we have funding that's commensurate with the need? Just give you a quick comment about that. As you guys remember, in 1985, Secretary of Health and Human Services Margaret Heckler introduced her Heckler Report, which showed that there are 60,000 excess deaths. And Dr. Satcher alluded to that, showing that number is up to 80,000 excess deaths that can be prevented. The legislative response in 1985 was to appropriate $3 million for the Office of Minority Health for the nation. The nation. We haven't improved that much since 1985. Then we have to have health statistics that are really there based on race and ethnicity. We have to be able to present that in readily understood, user-friendly information that the community can understand. Now, comment about the physician workforce diversity. You can see in this slide medical school graduates who plan to practice in an underserved area by race and ethnicity, that even among African Americans, only half plan to practice in underserved communities. Why? Because they have medical debt, because they have specializations that they want to pursue, and you know, we can't make this assumption. Although Cameromi and his colleagues in the New England Journal commented that African Americans and Latinos are more likely to go and practice in underserved communities, we're realizing that there's a paradigm shift in demands on these physicians. They're burning out, and they're not going to those communities. So that's something to recognize, and also, other physicians who are there, we're saying, well, how likely are the physicians who are remaining in these communities to be attentive to this issues of racial disparities? You can see by this graphic that when you actually ask physicians themselves whether or not they think that race ethnicity plays a role in healthcare disparities, only 29% of physicians agree to that premise, compared to almost half of the population. And so there's a disconnect in physicians themselves about this issue. So where do we go from here? What is our future direction? A landmark report was published in 1995 by the RAND Corporation, and they stated the simplest truth. It's so easy to read, but sometimes it's so hard to grasp. Healthcare is best delivered in the neighborhood. And this is my comment. In order to resolve healthcare disparities, healthcare must occur in a setting of systemic reform, true reform, which is approached in which is going to address uniform access to care. And it has to be provided in a holistic manner. We have to be attentive to the social determinants of health. Only when you can do that, only when you tie healthcare delivery and public health to the provision of actual stable, structured neighborhoods with livable wage jobs, affordable housing, and high-quality schools, we will actually see a reduction in healthcare disparities. Otherwise, we can spend money until the cows come home. But this is going to be an effort that has to interlink public policy with healthcare policy and clinical medicine policy. And ultimately, the last comment is that we have to go back to the argument that is necessary in terms of promoting elimination of racial disparities. We've backed away from the moral argument. Racial disparities are a moral argument. It's a moral dilemma. Until we recognize this, until we start using this language, we will not get the excitement, the passion that's out there in order to resolve and address this issue. Thank you.
Well, we're setting up for the final speaker of this morning's panel, Dr. Janetta Craig. I want to embarrass our students because they are the next generation in this area, so I want to introduce them. I don't believe Gia is here. No. We have 3 students working in our center right now. Mr. Gia Carbatza, Doris Castellanos Cruz, both graduate research assistants. Please, Doris, stand up. And Alicia Barnes, who is an NIH post-baccalaureate fellow. So, they've given us a tremendous amount of support and assistance this year, and we're looking to them to solve these problems with our help. And now we have Janetta Craig.
Thank you, Chris, and good morning to everybody. Actually, several people that have made comments this morning that lead into some of the comments that I'm going to make, and I would like to offer one depiction of actually a solution, at least a partial a starting answer to the health disparities that we are facing in this country. Advance. Go. Hit the wrong one. Okay. What I'm going to do is actually give you a brief introduction to the Health Resources Services Administration through the Bureau of Primary Health Care answer to health disparities. I'm going to give you a little definition of community health centers or federally qualified health centers, which is a synonymous term. The reason that we are called federally qualified health centers is that we are actually authorized through the division, the Health Resources Services Administration, through an amendment to the Health Centers Consolidated Care Act of 1996. It was actually Section 330 of that public health grant that allowed for the development of community health centers. Community health centers were actually started in the late 60s, but every 10 years we have to be recommissioned. Community health centers are locally driven. They are comprehensive primary care, disease preventive health programs. We are delivering care to low-income populations in medically underserved urban and rural areas. Our services are tailored to the populations that we provide, and as a result of that, every single community health center is different. Across the nation, there are actually 3,400 community health center sites serving 11 million people. In the state of Missouri, there are 90 community health center sites. In 2004, over 260,000 people were served in over 1 million encounters in those 90 sites that are located in both urban and rural areas. Again, we are serving both urban and rural citizens, over 11 million people nationwide. 33% of the patients served at community health centers are actually uninsured. 62% of the people served at community health centers are members of racial and ethnic minorities, and 64% of the people that are served at community health centers are living below the federal poverty line, which, as Leslie told you, is $19,350 for a family of 4. Oops. Now, I'm going to show you a very brief video. It's actually less than 5 minutes, and what this video is going to do is really give you a better understanding of what the Bureau's response is. And in 1998, under the auspices of the then director of the Bureau of Primary Health Care, Marilyn Gaston, the Health Disparities Collaboratives were born. The Health Disparities Collaboratives is an effort to define a care model, evaluation system that empowers providers and patients to make a difference in their health status.
I'm diabetic, I'm on insulin twice a day, and I never thought that my sugar would come down. But now it's down close to a normal range.
The more I take care of myself, the longer I'm going to be here.
I'm living now more so than I ever have before.
The best prices live more longer for me, you know.
It's a partnership where we work together to advance our own treatment.
There's the possibility for true systems change, and I never thought I'd see that in my lifetime.
Talk with just about anyone who works at a health center, and they'll likely tell you they're here because they want to make a difference in patients' lives. The best way to do this is by delivering up-to-date care to those in need and helping people get involved in their own care. That's what these Health Disparities Collaboratives are all about: changing practice, changing lives. The Bureau of Primary Health Care provides primary and preventive care for 12 million underserved Americans at more than 4,000 health center sites across the country. The Bureau has set an ambitious goal: 100% access to care and zero health disparities by 2010. To achieve this goal, the Bureau is sponsoring a series of health disparities collaboratives modeled after the Institute for Healthcare Improvement's Breakthrough Series.
The purpose of this collaborative is to break through the red tape, to break through bureaucratic systems, and to put in place as quickly as possible whatever it takes to help that patient get better, to help that patient get into a system of care, to help that patient live a better life.
La Clinica de la Raza serves a large, mostly Hispanic population in Oakland, California. In the shadow of the Rockies, Clinica Campesina in Lafayette, Colorado, uses the lessons learned in the collaborative in many areas of its practice. So do the Grace Hill Neighborhood Health Centers in St. Louis's inner city, which track their success with the help of a comprehensive information system. In rural Canton, Mississippi, the G.A. Carmichael Family Health Center enjoys great success with community outreach. Thunder Mist Health Associates in Woonsocket, Rhode Island, partners with their state's diabetes control program to spread the lessons learned to many other health centers. And Connecticut's Fairhaven Community Health Center has a weekly breakfast club for people with diabetes. These are just 6 of the hundreds of success stories from the Health Disparities Collaboratives.
I have controlled my diabetes from 400 down to below 150.
I have controlled my diabetes by exercise and watching what I eat.
There are lots of things that people can do to take good care of themselves so that they can be healthy with diabetes.
The Chronic Care Model, developed by Dr. Ed Wagner, director of the McCall Institute for Healthcare Innovation, defines the essential elements for improving the care of people with chronic illness. There are 6 components. Patient self-management. Patients learn about their disease and how to prevent problems. They set goals for themselves, and the clinical team supports them in attaining these goals. Decision support. Clinicians use evidence-based practice guidelines and protocols, applying the most current knowledge to help their patients. Clinical information system. Health centers create a registry, a database of the entire population of those with a chronic condition, and a checklist of what needs to be done to care for them. The registry enables the care team to guide the course of treatment, anticipate problems, and track progress. Delivery system design. Patient visits are planned well in advance based on the patient's needs and self-management goals. For example, people with diabetes can see their primary care physician and visit the nutritionist, dentist, and foot doctor during the same visit. During group visits, patients see their clinician and then have an opportunity to meet with other patients with similar health problems. Organization of healthcare. Health centers are committed to improving clinical outcomes and make organizational goals for clinical illnesses part of their annual business plan. Senior leaders and clinician champions are visible and dedicated members of the team.
So, as I said, these healthcare collaborators actually started in 1998, and almost immediately, within the first year, just in diabetes alone, for example, there was a 300% increase in the number of diabetic patients enrolled in the collaboratives across the nation who actually had 2 hemoglobin A1Cs done within a 90-day period. That is one of the key measures of the Health Disparities Collaboratives. There are actually 6 Health Disparities Collaboratives that are currently in operation. They include diabetes, cardiovascular disease, asthma, cancer prevention, and depression. The Department of Health here in the state of Missouri developed a scorecard for the 11 health centers, actually there are 13 health centers in the state of Missouri that are participating in Health Disparities Collaboratives. This scorecard was an attempt to show us how we are performing, to allow us to compare our performance to the other health centers in the state, and also to compare our performance against benchmark goals. So far, we've done some amazing things, and I just want to, this is unreadable, but this is the whole scorecard for diabetes and for cardiovascular disease. I'm just going to give you some of the highlights of what actually has happened through the work of these Health Disparities Collaboratives. very impressive is the fact that of the hypertensive patients that are enrolled in the Health Disparity Collaborative on Cardiovascular Disease, 58% of those patients are actually achieving a goal blood pressure of less than 140/90. This is amazing because Dr. Ross will tell you, as a nephrologist, only about 30% of hypertensive patients across the nation, in general, that's the entire population, actually achieves goals like this in terms of hypertension control. One of the major things, and in fact one of the major focuses of the Health Disparities Collaborative, is the whole issue of self-management and engagement of the patient. And again, one of the great successes of this Health Disparity Collaborative is the fact that about 46% of the cardiovascular disease patients and 53% of the diabetes patients have actually been engaged and are active members and controllers of their process or management of their disease because they have written self-management goals. I'm not going to take a lot of time to give you more detail because we've got a lot of people and we're going to answer questions later on, but the Health Disparities Collaboratives truly is a silver lining. I'd like to say we've done some incredible things. Like everything, the funding is not there, unfortunately. The goal of the Bureau of Primary Health Care is that every community health center across the nation will, by 2010, be involved in at least one health disparity collaborative. We're still waiting and hoping that that happens because, unfortunately, one of the major challenges with trying to run these disparity collaboratives is the fact that the funding is limited. And as you realize, or may not realize, that community health centers, although we are a safety net provider and we do receive significant funding from the federal government because of our administration through the Bureau of Primary Health Care, we are significantly dependent upon Medicaid funding. I can say for my own organization, our revenue stream is 80% dependent upon Medicaid revenue. And with cutbacks in Medicaid, our overall program is going to be tenuous, and we're quite concerned about these changes as they come down the road. Thank you.
Thank you, Dr. Craig. We're running a little bit behind time, and so I think I'm going to take this opportunity just to thank our panel and say what a tremendous group of experts we have here and some fascinating work. And instead of asking questions as a group, let's give you the opportunity in the next break to approach them individually and get to know them and to make contact with them. And that will help us keep on schedule. I'm sure you've heard the Capitol Plaza freight trains have been delivering our lunch behind us. And so we will go ahead and proceed to lunch at 11:30, and we're in the room next door. So thank you again to our panelists. Tremendous morning.